The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Good morning, George. It's Tuesday morning, and we have a friend, a personal friend, on the podcast today.
Yes, today we have a very old friend, one of my very first in medical school, Dr. Jeff Sadowsky, and his topic is going to be not a pediatric one, but related to pediatrics in a way, a day in the life of a Tele-ICU physician. Take it away.
Dr. Sadowsky is in Florida, and he's double board in internal medicine and ICU medicine. He worked at Orlando Health System as corporate medical director of several adult ICUs throughout the health system. And he founded Robotic Critical Care Services, a service that helps hospitals take care of their critically ill patients, adult patients in the ICU. Welcome, Jeff. It's great to see you.
Good morning. How are you all?
How's the weather today?
Today, it's better. It's been cold. It's like in the 40s at nighttime, but it's supposed to go up to 70 or 80 today, so it should be during the day. That's good. Can't complain. Not to say.
Great. So, Jeff, why did you become a doctor?
That's a good question. And to tell you the truth, I actually had to think about that when I was talking to a facility in Arizona. I wanted to give them an internal look into myself because I was wanting to bring Tele-ICU to them. And I really had to sit back and go through my life and think about it. And it sounds like an easy question. I knew I wanted to be a doctor since I was in 3rd or 4th grade. But when I went back and I thought, it goes back to helping people. I have the desire to help people. When I was a teenager, I became a lifeguard. Why did I become a lifeguard? I wanted to save people. I wanted to help people. Then I became a doctor also because I wanted to help people. I decided to go into critical care medicine because I wanted to help the critically ill patients. And then actually I found myself in telemedicine, tele-ICU. Why? Because I wanted to bring my subspecialty to patients at facilities that did have our subspecialty. So the whole theme of this is I just like helping people. So that's why I went into medicine.
That's wonderful. And how did you meet George?
George, I met in medical school. We went to medical school in Romania. At the beginning, he was very green. He looked like a deer in headlights a lot of time, but we had a great time there. However, it was the 1980s. I graduated in 1989, right when the Berlin Wall came down. And that year, they actually had an uprising in Romania and executed the dictator Ceausescu and his wife. It was tough. George and I have a special bond because we went through a lot of hardships together. Both of us are from New York. Both of us are from middle class. And I found myself in the middle of socialist or communist Romania in my late teens, early 20s, and coming from Long Island, New York. And all of a sudden, people are telling me, nope, you're not allowed to drive your car between November and April anymore. Or when you can drive your car, you have a limited number of gallons that you can actually get that were allotted to you. You were allowed 50 liters a month. 50 liters is about 12 gallons a month. Cooking oil. We were allotted 1 liter of cooking oil a month, as well as sugar. We were allotted 1 kilogram, so 2.2 pounds. That was all very new for me. Going to a store and not having things available to us was really unheard of in the United States. So we had a lot of interesting other things. I was always cold. And certain times during the day, the dorms we were living in, to save electricity and money, they would just turn off the electricity. And we would have no electricity for several hours. And this would be on a daily basis. So that means no hot showers. A lot of us actually didn't remember the boilers. We went out and bought boilers for our bathroom because there was no hot water.
But you had money.
Yes.
You had nothing to buy with the Romanian black market money, but you still had money.
That's right.
Yeah.
So that's how we made our bond. Now, George was 1 year younger than me, so he was there a year after all of this stuff. But
I was there during the entire revolution.
Mm-hmm.
I actually was working in the hospitals when they were shooting on the streets.
Yeah, it was crazy.
Yeah.
I was home at that time.
Yeah.
Now, when did you meet Delia, Jeff?
Oh, I met Delia right when almost right
Yeah.
when George met her, because we were friends and Delia's his better half. What can I say?
Oh, definitely. It's the brains behind the organization.
Yeah, she's great.
Yeah.
We were a year ahead of them, and so we did a lot of stuff together. They were able to learn from our experiences, pick up from our mistakes, and not make the same mistakes we did. There were good times also. There's a lot of studying, a lot of studying. And that's one of the things I really liked about that, not that I liked, that was good for me for Romania, is there was not that many distractions. You're there in a communist country, and there's not much to do. There's not going out to the discos or to the bars and stuff like that. It was really geared for studying. So that helped me a lot.
The restaurants closed at 9:00. Remember?
That's true too. Yes.
Yeah, so you had nothing to do. I remember going to Romania once, coming from the United States, a pocket full of money and nothing to eat. That was pretty sad.
Mm-hmm. Yes.
Yeah. Did Delia speak English from the very beginning, or did she learn it by hanging out with you guys?
She spoke English.
He spoke it. Most of
them
educated, Romanians already spoke some English. I think her English got better. We spoke mostly Romanian, though.
Yeah.
With her.
Oh, wow.
There was a network of kids that went to school, and we're all friends here pretty much in the United States. And it was a close time, I think. I try to see Jeff at least once or twice a year when I go down to Florida. Been doing that for years.
Yes. When I'm in New York, I try to see him also.
Yeah.
A couple of times.
And then tell us what you do today, because it's all this talk about AI and natural language models and blah, 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 blah. You've been doing actually a lot of this already.
Yeah, with the telemedicine, I actually started the first program at our Orlando Regional Medical Center, and now it's called Orlando Health, back in 2011. All right. So this is 13, almost 14 years ago, where nobody knew what telemedicine was or all this stuff. And I was tasked to start a Tele-ICU coverage for two of our sister hospitals during the night. And then that was in 2011. 2012, the third house, the corporation acquired another hospital, and they wanted us to cover that hospital also. And we started using this robot. I think it initially aired on one of the ER TV shows back in the day. And it's a robot that's about 5 feet tall, and you can drive it around. And it's got on the monitor head, which turns around, got a stethoscope on it, and so forth. We started using this model. We had an intensivist during the daytime, and then at nighttime, we would cover via the robot these 3 hospitals. And it was interesting because when we first started, we thought it was just going to be an on-call tool that we'd be able to beam in, take care of a problem, and then move on. But as we saw the capability of what we can do with the robot or the cart, we actually turned it into a pretty comprehensive program where we saw that we can actually see patients, do a pretty good examination. We had access to the EMRs, so we were able to see the labs, the X-rays, the CAT scans, and so forth. We were able to put orders in, and then we were actually able to do a full note, a comprehensive note, from going from just an on-call, putting out fires tool to a really comprehensive program. We're able to do full H&Ps and admissions, consults. We're able to even run codes. We're not the people actually doing the CPR or the intubation or whatever, but to actually run the code, I'm sure it's similar in pediatrics also, is that you've got usually the doctors at the side of the bed checking the pulse. In adults, we would check the femoral artery pulse, and so you'd have one person doing the CPR, one person managing the airway, one person doing the medications. So we can do that via telemedicine also.
Yeah, hold on a second, Herb. I remember him telling me that you're running it like you would if you were in person, with rounding, with notes, and it was just like a regular ward unit.
Yeah, if talking about the workflow of it, yeah. So what I did was I mimicked the in-person workflow. So what happened initially is we got this robot, and they said the robot can do this, the robot can do that. You can drive it, you can turn, you can have a stethoscope, and blah blah blah. But still, it didn't really fit into our usual work. We didn't know how to use it until because everybody kept on saying this is what the robot can do. Finally, I looked at it from a different perspective, from that silly movie RoboCop. And there was RoboCop 2. It was when Murphy, the police officer, gets shot, and they put his brain in a robot. and the robot became an extension of himself. So once I thought of the robot becoming an extension of me rather than what the robot is and what the robot can do, the robot can't do anything without me. So as an extension of myself, what can I do with the robot? So then what I did was I was able to mimic the daily routine of a physician. So for example, day shift, we would get a warm sign out from the night shift doctor about the new admissions and so forth, what's going on. And then what we would do is we would beam in, usually in between 8 and 9, 8 and 10 in the morning. And we would go and start doing rounds with the bedside nurse, the charge nurse, and respiratory therapist. And we would go into each room and talk it over with the nurse, examine the patient. If we were able to talk to the patient. If they're intubated and sedated, we would do a physical examination, which we can do with the bedside nurse. We can look at pupil sizes, check for if the pupils are dilated or if they're reactive. We can look at the neck. I'm an old doctor. We would look for JVD. We could listen to the heart sounds, the lung sounds. I would ask the nurse to palpate the abdomen. Can I tell if the liver has a sharp edge or if it's too low under the diaphragm? No. But what I'm worried about is, do they have an acute abdomen? So I can talk the nurse through doing rebound, see if there's any guarding, anything like that. Plus, I'm visually examining the patient. I would then go down to the legs and see what the pulses are, +1, +2. Ask the nurses to tell me, look for edema, capillary refill. Then what I would do is I would turn the patient on their side and I would look at their back, see if there's any decubes or pressure ulcers or anything like that. If there's modeling, if there's cyanosis, if there's rash, I can see all of that very clearly on the robot. What we do then is we come up with a plan for the day and we discuss it. And then I would drop it in a note and move on to the next patient. At nighttime, we do very similar thing, is that we just don't have to write the note. And we don't do a physical exam on every patient at nighttime if they were examined in the daytime. If there's a problem during the night, patient becomes hypotensive, has a seizure, has respiratory issues or whatever, we'll beam in and do a focused examination. If we get a new patient during the nighttime, then we will also do a full examination and come up with a plan. Same thing at nighttime. We get the bedside nurse, the charge nurse, the respiratory therapist, and we go to every patient and we eyeball them, come up with a plan for the night, put in any orders that need to be put in, and then move on to the next patient. The other good thing with working remotely, so we have patients and hospitals throughout the United States. So we're in all the different time zones. And most ICU patients, the staff want us to be there early in the morning and come up with the plan, make the vent changes, make any changes, come up with a plan and start executing it. So with telemedicine, I'm Eastern time. So I'll see my Eastern states in between 8 and 9 my time. Then I would go over to my Central states. It's 9 o'clock my time. It's 8 o'clock their time. I'll see them in between 8 o'clock their time, 9 o'clock their time, which is 9 o'clock my time, 10 o'clock to 10 o'clock my time. Then I'll go over to my mountain patients and then see them. Again, it's going to be 8 o'clock for them. It's going to be 10 o'clock for me. And then I'll go over to my Pacific Coast patients and then see them. It's going to be like noon for me and it's 9 o'clock for them. So I can actually see all of these patients in between 8 and 9 their time with just working my workload from my home in Orlando.
Why don't they just hire a physician?
Great question. So physicians are expensive, and a local physician can only be in one facility at one time, really. So what happens is, and there are lots of places that are remote, and they can't get a physician to live in these remote areas, especially a subspecialist like an intensivist or a pulmonologist or certain subspecialties. Number one is these smaller, or not always necessarily smaller, but usually the more rural hospitals have access to our subspecialty. Number two, it's going to be more cost effective because with telemedicine, you're really only paying for that part of the physician that you're actually using. So instead of paying a physician to be there all day, you're paying a physician to be there for a certain amount of time, or we actually have it set up to patients. So if your average daily census is 2 or 3 patients, you're only going to pay a small amount of money. Whereas if your average daily census is going to be 18 patients, then that's going to be like almost a full-time physician salary. So they're really like leasing a physician, leasing that part of the physician. So it's definitely cost effective.
I guess that's good for them, because if before they had your services, what would happen with those patients? Because the patients are going to show up critical wherever they are, right? They'll have to ship them out or something?
Yeah. So most of the time, if they don't have the subspecialty, then they're forced to ship them out. Or sometimes certain hospitals will try to manage with hospitalists or physicians that are local. But if the physicians locally don't feel comfortable, they're going to need to ship out the patients.
Interesting. So you said something interesting that the robot has a stethoscope.
Mm-hmm.
Does the nurse have to put the stethoscope in the right place? Or okay, I just wonder if they have like a robotic arm, you can put it on where you want.
Not yet. Once they get the robotic arm, I think we should be able to start IVs and do central lines and intubations once we get.
Why don't you tell us about technology? Yeah. Why don't you tell us about technology you use?
I have one more question. Are you using algorithms like for early sepsis?
So we use the same stuff that we do with the in-person stuff, with the in-person algorithms. It's nothing really specific. And we leave that up when we discuss with the site and what they're available, what their availability is and what they can do. Because some sites are very rural, and some sites are, one site we were dealing with, they have an 18-bed medical ICU, an 18-bed surgical ICU. They see neurosurgical patients and so forth. And it's a teaching hospital. So we're seeing the whole gamut of patients. With the sepsis bundles, that's what we're really looking at, and the sepsis guidelines, that's what we go about. And it depends on the hospital if they want to have all of those incorporated. Some of the hospitals have them incorporated. Most of the hospitals have them incorporated already. Some hospitals don't have them, and then we would recommend them.
Yeah.
Even
does it work? Jeff, does it work? Does it detect sepsis early? Does it work, or does it make you do a lot of extra work?
There are a lot of false positives because the initial indicators are going to be increased heart rate, tachycardia, fever, increased respiratory rate, on low blood pressure. And there are a lot of other things that can cause that. Just an anxiety disorder can cause that, or somebody that is other things going on. Post-surgical patients also can have some fevers post-op that are not sepsis. So you do get a lot of false positives. However, that's where the bedside nursing comes in, or the rapid response teams come in. They can decipher what if this is really, if it looks like sepsis or not. And the ones then that do look like sepsis, then the bedside nurse or the rapid response team would then bring us into the bedside once they believe that it's true sepsis.
Yeah. Are you using any other algorithms in the ICUs that are preventing other bad outcomes right now, or is that the main one?
It's right now we're using mostly just the bedside nurses and the monitoring. That's really what we're using. There are some larger hospitals have different things set up to their monitors or to their EMRs that will then alert bedside nurse that something bad could be happening. I think there's the Richmond system also can do that. But for the most part, it's just what the hospitals have already set up.
Yeah, I'd like to hear about the technology because I remember this, and you had a lot of, it was like a command center. I presume now it's down to an iPhone level and FaceTime. It's probably a little bit more complicated than that.
Actually, so everybody's so into the technology, just you are, which is great. I love the technology part also. But so yeah, in my office, my home office, I've got my laptop and I've got a big monitor screen. And I like the multiple screens because I can be looking at the patient on one screen, having the EMR open on the other screen. So while I'm talking to the patient and the patient's family, I'm scrolling through the EMR, I'm looking at the lab work, I can pull up the x-rays. I can actually take the x-rays that are on my screen and put them into the cart and show them to the patient and to the patient's family. That's where the technology comes in. But really, it's the force behind the technology. Actually, when I do a talk, I use a couple of slides from The Wizard of Oz. Big Oz and the wizard. He's got all these things going on and the puffs and the fire and stuff like that. But actually, it's the guy behind the scenes that's actually managing everything and running everything. I think that we're like that also. And that was the initial thing that I had with the robots, is that it's what they can do, what they can do, what they can do. But it's really how we use their technology. So really, you're right, George. We can do video visits right from our iPhone right now, which is very cool. I like to have a secondary screen at least up so I can see the patient's chart and actually do some charting while I'm talking to the patient and looking up the stuff, looking up their data and stuff like that. It also helps because as I'm at the bedside, as I'm talking to the patient, I can actually be putting orders in. I become more effective with all of this. Now, on the other side, the carts and the robots, and the major difference between the carts and the robots, the carts I refer to as it's a monitor on wheels, where you've got a monitor, you've got a camera, and you have to have one of the staff push you and pull you around. The robot it's more sophisticated, where we can actually drive it with our mouse and so forth. The last one, the third one that I'll talk about is some places have a screen and a camera installed in the patient's room. This is the least one of my favorites, is the TV, the monitor, and the camera in the room, because you're not mobile. And lots of times what I'll do is before we go in to see a patient, I'll do a quick little huddle with the nurse. What's going on with the patient? What are the concerns? How's the family? To see what's going on, even to find out some of the drips that the patients are on, because we can't keep up minute by minute with the drips. And when we go in and we say, what's the levofed going at? It's a normal question for us, but the family interprets it as, why don't you know what the levofed is going at? Well, it changes every minute type of thing. So we don't want to give that impression. I like the robot the most because it's the most flexible and independent. I can drive it in, I can drive it out. We can talk to the nurses outside, inside, family members. Sometimes the family members want to step outside and talk to you in private. You can't do that if you've got the screen and the camera in the patient's room. That's what I like the most.
When I started using this AI scribe, I was a little concerned about what role it plays in the relationship between or us as a parent and me when we're communicating. I think I think it's so hard to deliver bad news, even if you're sitting next to the patient. How does that interaction through a piece of metal work?
It's a great question. So with my experience so far is when we have the difficult conversations, back in the day, let's step back for a second. Back in the day, lots of times doctors weren't there at nighttime. And in the smaller places, the physicians aren't there at nighttime. And these family members were getting news over the phone, right? And now when we are there remotely, they see our face. They hear our voice crack. They see the compassion and the empathy that we have. That goes through. They can connect with that. It's not, Mrs. Smith, I'm sorry for your loss. It's the person. It's the person behind the screen that's on the screen, and they see that you're upset, or they see that they can sense it. They see it, they hear it. So giving the bad news, is it the best coming through a computer? No. But I can tell you there are a lot of doctors that don't know how to do it.
Oh, yes. I'm just old school. I was taught you don't give bad news over the phone. Back then it was just a phone, not even a cell phone. But you don't get bad news over the phone. You ask the family to come in, and you sit down with them and you talk to them. Not that I did it. It took 30 years to learn how to do that. But
it's bedside manner that we actually flipped over and turned into what we call webside manner now. I was at a facility in New Jersey, and I went in with the robot and started talking to the family, and the family was very aggressive. They were well, where's the real doctor? Where's this? Why did it? Mother had an intracranial bleed, right? Did a whole full exam on the patient, and I actually pulled up the CAT scans and I went through it with the patient or whatever. And they said, where's the real doctor going to come? I said, the pulmonary critical care doctor will be in shortly. There is one at this facility. Knowing his bedside manner is not the best. Actually, his bedside manner is not good at all. But he'll be in. Later on, towards the end of my shift, I was circling back to check in, doing like my walkthrough, just like we do in person. You walk the unit, and I stopped at the patient's room that was aggressive, and they came up to me and they said, "We like you so much more than the in-person doctor." It's really how you present yourself. I think that you can get through the metal and nuts and the bolts and the electricity and the wires.
Do people have a name for the robot?
So with the robot, the company that started with these, it was called InTouch Health. InTouch Health was later bought out by Teladoc. They would have a naming of the robot. So they would have a name. Some would call it, at my facilities, we named it RoboDoc because it was masculine, it was good, and most of our physicians were male. Then other places, they named it like Rosie from the Jetsons.
Yes, from Fights of the Yard.
Want to be a Rosie? Some places called it Max. They just came up with a name. Yes, so they would say it like that. But sometimes they would call us like a doc in a box. I didn't like that.
No, it's never a good thing to be called. And if families respond okay to the interaction with the machine, And how do you know that when you've connected with them? What have you seen people do?
A great thing that came up, I was doing a talk, I was on a panel, and the last question they asked was, how would you rate your success? And this was not in our list of questions that they were supposed to ask us, so it was just out of the blue. And so they asked the guy next to me, he was from the Mayo Clinic, and he went through all of the data points. So decreasing length of stay, decreasing vent days, turning over ICU beds quicker, return of investment. Blah. So he's going through all of them. And I'm sitting there, I'm saying, I hope he doesn't ask me. I hope he doesn't ask me. But me with my Murphy's Law stuff, good luck is that, of course, he asked me, Jeff, how would you rate your success? And I'm on this panel and I'm in the middle of, I don't know, a couple of hundred people. And what came to me is that it happened at least 2 or 3 times with the robot that we can actually drive around, is that when you're in the ICU, you're in the family's face every day, right? You're talking to them every day, sometimes several times a day. And you gain a rapport with them in person and, as I saw, even virtually. Because at least twice this happened, is that when the patient was ready to leave the ICU and we were saying goodbye, I was saying goodbye to the family, even though I was in Florida and they're in New Jersey, they actually hugged the robot. They actually put their arms around the robot and hugged the robot. So what that tells me is that we went through Wi-Fi, metal, bells, buzzers, wires, bolts, nuts, whatever it is, and we connected. And it's a significant connection.
Wow.
Yeah.
The good quality medicine.
It's a good quality
And
medicine.
the other stuff was the money. They put the money first at the hospitals.
Yes. Yeah. And it's the bedside manner. It's the bedside manner. If you look like you're interested in you, and that's another thing that I liked. So it's the only company that does it. Was the InTouch Health and Teladoc now has it, that their monitor screen moves. When I turn to somebody, it's the monitor moves, not necessarily the base, right? Because what happens lots of times with most of the models where you got the monitor here and the camera's on top, the camera will move, right? So if somebody's sitting to my left and I turn, the camera will move, but the monitor's still looking straight. The person could be behind me and they can't see my face. Whereas with the InTouch Health Now Teladoc equipment, when I turn to look at them, the whole monitor moves. So now I'm looking at them eye to eye. That, I think, it's a silly thing because it's a cart, it's a monitor. But when you're looking eye to eye, now, if you see me looking up like this, I'm not as engaged as when I'm looking at you in your eyes.
Yeah, absolutely. Yeah. And it's interesting because something you said, that George is fascinated for the wrong reasons with payment formulas. And people forget that sometimes quality is not important. Somebody has a devastating brain bleed before they get to the ICU. What is the best outcome? A quick death. There's no recovery.
Right.
And there's nothing you can do as a doctor to change that. What is really valuable in what we do is not return on investment, gag me fee for service, value of care payments, all that nonsense. What is valuable in medicine, the work that we do, is the impact. So that lady with a brain bleed may not be salvageable. She's going to die no matter what you do. But how you help that family through those last moments has an everlasting impact. And that's why I get so irritated with these communists that only want to talk about value-based payment, because they're losing the sight of the humanity of the work that we do, which is the impact that we have. Sometimes it's just on a family. Sometimes it's on the whole community. And that's really the value of a physician. Sometimes we can't change the outcome. It's impossible.
Yeah. And usually the words you tell them, the last words, those are the words that are going to stick in their mind for the rest of their lives. And the other thing, and depends how you say it, is going to be very important. The other thing is I get thank you letters from families of patients that have died more than I get thank you letters of patients that have survived. You're embedded in their brain for the rest of their lives. It's an important time.
Incredibly vulnerable time too, right?
Mm-hmm.
You're losing a loved one and you don't understand the system.
Yeah.
And we all know that we are all going to die, but what's the word that we use? We're in constant denial.
Mhm.
None of us acknowledge that we're getting older and that we're going to die someday, because it would be just miserable to wake up in the morning.
Yep.
And now they're having to face that. And your words are everything that they'll hold on to for many years. When we interviewed, Tony said that people can remember the glasses you're wearing, the color of your hair, the color of the shirt that you were wearing when you told them there's nothing else to do.
Mhm.
It's such a vivid memory. They know every detail, like whether you're sitting down, standing up, the color of the wall behind you. That's the beauty of medicine. You can make an impact by
Mhm.
just being a little nice.
And compassionate.
Yeah.
And that's medicine. That's bedside manner. That's not something that's, I guess it's taught, but it's learned over time. And I think that's being lost. You have to have, I consider a physician, especially a physician like you, Jeff, like a Jedi master. You have to teach the Pod 1 learners. And those learners with these computers, you know how many backs of heads I see with doctors on the computer chopping away? They don't even talk to their patient. That's why Herb was talking about the AI scribes. I don't even type anymore.
Mhm.
I just let the thing work and I bring it to an office and I drop it in later. Yeah, I think that's much better. Now, insurance companies, I'm sure who pays for all this stuff, sir? It sounds like expensive stuff. Hospitals or...
The way we have it set up is the hospitals pay for our services, their equipment. So we can help guide them to which equipment works best, at least for us, and give them some recommendations. But the hospitals, they pay us a stipend for the shift. Again, we have the way my company works is we have it set up as number of patients based. So census, what's your daily census? So if some hospitals, their daily census is 2. Okay, they're paying not much. Other hospitals, their daily census is 20. They're paying more. What we also do to offset that is that we assign our billing back to the hospital. So the hospital does our billing. So for critical care time, and it's really just critical care time that we're billing for the most part, they get to bill under our name and they get reimbursed for that amount of money.
Sounds like concierge medicine, I guess.
You can look at it as fee for service. You're paying for our time. And then again, if you're just using a little bit of the time, you pay a little bit. If you're using most of our time, then you're paying more.
Interesting.
And how many patients, when you're on service, how many patients are you expected to be taken care of at once? Because you got patients all over the country. So
correct. So day shift, it's usually somewhere between 15 to 22. Because we have to we're doing notes on all of these patients, and usually days are a little bit more hectic. Night shift, we can see a little bit more. We can see somewhere between 40 to maybe up to 50-ish. It depends. You get one sick patient, and there goes your whole night. But a lot of it is, okay, DKA, not a problem. Let's move on to the next one. This one's stable. So at night shift, and you don't have to do notes on all of the patients. Night shifts, we usually get an average of anywhere from 2 to 10 new patients a night. And we round on every patient. It's not like we're in a command center where we're overseeing 100, 150, 200 patients. We actually are going in and seeing every patient every night. So that kind of differentiates us from the bunker model or the more of the EICU type of model where there's a command center and you have a physician just sitting in a cubicle in an office building somewhere. Here, most of our physicians are at their home. But we can't see as many patients because we are actually seeing every patient. And when the nurses call for us, they get the position. It's not a nurse. It's not a nurse practitioner or an APP. They get the position.
Yeah. So that helps with work-life balance.
I was going to ask you,
right?
Before we move on. So what happens if you have 2 really critical care? Do you have a backup on-call doctor that you could call because you're going to be tied up for 2 hours with someone?
Of course, yeah. We actually have 2 backup physicians every night because we're so busy, especially during COVID. We were seeing patients up the wazoo. It was crazy busy. The only good thing from a physician point of view is instead of seeing 30 or 40 patients that each have different diagnoses, they all had COVID, all COVID, respiratory failure, on event and sedated and might be paralyzed, may not be paralyzed, so forth. So that helped out with that. But we definitely have 2 backups on every night. The other interesting thing that my more experienced users and providers can do is they can actually be beamed into 2 or 3 different sites at the same time if they're using different technology. So I can be beamed into one facility on my laptop, I can be beamed into another facility on my tablet, and I can be beamed into a third facility on my iPhone. So I can actually see 3 different places. I just have to remember to mute the ones that I'm not communicating with.
Yeah.
Those are my experience.
And how much, see, I think of DKA as a pediatric illness.
We see
How much of your work is DKA?
It depends on the hospitals also, but there's certain hospitals where we see 2 and 3 a night at one hospital. So certain facilities we're in, there's high alcoholic population, so we see a lot of alcoholic issues. In other places, DK is pretty prominent. And then we've got the DKers, we'll get the teens. They're still 17, 18, 19, 20, 21, that they don't like taking care of their DK, their diabetes, and they end up with DK multiple times. So yeah, we see a lot of DK.
Do you see a lot of them dying?
Dying? No.
No.
DKA in adults, very rare would they die. Now, if they're older and with some of the complications, but I don't think I've had a patient with DKA die. Not from DKA, at least. In adults, and I don't know how you have it in peds, but in adults, most of the DKA protocols out there, they work. You put them on the DKA protocol, and it's all protocolized. There's not that much that we actually have to do.
Well, and this it sounds like an emotionally straining job, like especially during COVID. And at least you didn't have to be in the patient's room fearing that you would get COVID. But
Correct.
How's the work-life balance?
Let me tell you about COVID for a second. COVID, we were great because, first of all, we were able to be available for hospitals, big hospitals, small hospitals, standalone emergency rooms that actually had patients that were stuck there because there was no place for them to send them out. We were able to help facilitate those. The other thing is absolutely right. We didn't have to go into the room. So I'm sitting here in Orlando taking care of these COVID patients. So I don't have to go through all of the PAPRs and the isolation and so forth. Thirdly is when we were going in with the nurses, if we didn't have to go in, we could see everything from the window. We have a zoom on our cameras. So we can be at the window and we can zoom in and see the monitor, see the ventilator settings. We can actually zoom in on the patient. I actually diagnosed the patient that was seizing because they were just having twitching of their lip. And you couldn't see. And I was at the door. I was right outside the door looking in. And so it was definitely great. So for us, and I even had a note set up. So my regular physical exam and my COVID physical exam. My COVID physical exam stated I'm outside the door. I'm unable to listen to the heart sounds and lung sounds due to the fact that they're in COVID isolation. I see that the rhythm on the monitor is almost on its rhythm, it's on a stack, whatever AFib, and it was very good. Plus, we didn't have to put the nurses or any staff at increased risk for going into a room. So sometimes the nurses would say, I have to go in to bring a medicine. All right, if you're going to bring a medicine, take me in with you, and then I'll come in with you, and we'll listen to the heart sounds and lung sounds and stuff like that. So that's that. Stress and work-life balance, in the ICU, it's always stressful, and there's always ups and downs in the ICU. So that in person and virtually, it's pretty much the same. With the thing with work-life balance with me is that number one is for my physicians, I've got three visions I have for my physicians. Number one is that they are professionally satisfied. I want them to feel that what they're doing is for the right reasons and feel good about it. And to tell you the truth, that's the number one reason my physicians are doing this. They love going into rural areas that our subspecialty is not there, and they're able to provide care that they were not able to provide before we were there. The gratitude and the appreciation we get from the staff is amazing, and it brings up the morale of the whole unit, of the whole staff and the unit and the hospital. So number one, it's professional satisfaction. Number two is financial satisfaction. I want my physicians to feel like they're getting reimbursed appropriately for the amount of work they're doing. And doctors are good with that. And I've been in the situation where I don't want to position any one of my physicians to feel like they're working so hard and not making the amount of money that they feel is appropriate for them. And that's my second. The
You
third,
mean like pediatrics?
yes, you got to come work for me. And then thirdly is work-life balance. I have certain physicians that are young and they want to work, and make a ton of money. I let them do that. I've got other physicians that don't want to work as much. They want to make some money on the side and they want to work 2 days a week, 2 days a month, whatever it is. And so we do that. The physicians kind of self-schedule. They give me their availabilities. All of my physicians are 1099. They give me their availabilities, and then I put them in the schedule according to that. They want to work a lot, they work a lot. They want to work a little, they work a little. They don't want to work this day or this weekend or this day shift or this night shift. They don't have to. The other thing is, again, they're working usually from their home. Okay, so they have a home office. So when they get a break and they want to get a cup of coffee, instead of going down to the cafeteria and getting a cold or a bad cup of coffee, they go into their kitchen and make their own coffee. If they want to grab something to eat, they can do that. What I do lots of times is for nighttime, after sign out, I get sign out at 7. I don't sign into the hospitals until 8 or 9. I can actually go out and spend some time with the family if nothing's going on, and then come back and do my rounds. And then so you have the flexibility of being at home. Plus, also, some physicians do this is when they're going away, they're going to be at a conference or they're going to be on a vacation. I don't like to do it on vacation, but they can actually cover shifts when they are out about. Really, all they need is their laptop and Wi-Fi, and to be in a room that's HIPAA compliant, meaning that a room that the door is shut, there's nobody else in the room with you.
Oh, you make it sound very easy, but I don't think it's that easy. I remember when I come to Florida, I have to pre-schedule with you a couple of months in advance.
Yeah.
This day of the week I can come and see you.
Don't forget also, I'm the owner, so the buck stops with me. So if somebody calls in late or calls in, not many of my doctors' physicians don't really call in, but I had one physician that he was busy at one hospital and his phone fell behind his desk and he didn't realize because he was busy with this one hospital, and another hospital couldn't get in touch with him. So they called the backup, which was me. So at 1:00 in the morning, I got to get up and go and see these patients. I had this very rarely happened, but I had one physician didn't realize he was on call. And so that very rarely happens, but it did happen a couple of weeks ago. And then and it was a Friday night. So it was a good thing I was available. I was the backup. I did the night shift. Yeah. And then running the business, the medicine part is the easiest part out of the whole thing.
For you.
For the whole
person like you, for a
Right.
person like you.
But getting a program started, its implementation takes weeks to months. Getting licensing and
Yes.
credentialing and training and getting all the parts and pieces together, and even talking with training the nurses to how to respond to certain things. So for example, now the nurses know before they push in the piece of equipment which we're attached to, the monitor is to tell the family, hey, this is Dr. So-and-so. He's a physician. He's licensed in this state. He's credentialed at this hospital. He's just like any other physician. He's going to come in. He's from Orlando or whatever, and he's going to be able to see all this stuff. So instead of just pushing a piece of equipment in with saying, what is this? They get a little preview of what we are and what we can do.
Interesting.
And why do you think the morale goes up?
Because they get to take care of sicker patients. They get to keep sicker patients at their hospital. And then they see their patients, most of the patients hopefully are getting better. On the other hand, it is crushing when they're not used to dealing with death and dying, and these hospitals will have some more of the death and dying conversations. But I think the reward to actually see a patient through is extraordinary. We just started at a facility, we started last year at a facility in Arizona, in Navajo Nation. It's a critical access hospital. Never kept vented patients there at all. We had to actually, from our point of view, we were ready to start right away, but we needed ICU nurses, and the nurses were not ICU nurses. So we had to help educate the nurses to get them up to the standard. But we had our first vented patient. It was interesting because every day, so that the patient came in alcoholic, developed strep pneumo and pneumonia with sepsis and septic shock. Every day I beam in and they're like, can we extubate today? And I'm like, no, we're still on this amount of support. And then the next day, and then the next day. And then I'm like, why do they keep on asking this? It's because they don't understand an intubated patient. They're in their mind, you put them on the ventilator and they come off the ventilator. So I had to go through with them that, no, the body has to heal and certain things have to occur before we can move to extubation. And this patient was on the vent, sedated, intubated for a week, 7 days. And we got him off the ventilator successfully. And his family was at the bedside, and everybody was really happy. That brings up the morale. Person actually left. They were able to take care of a sicker patient. They learned, and that is going to bring up the morale.
Wow.
So you're an innovator and entrepreneur and know how to use technology.
And a Jedi Master.
A lot of people talk about technology, this technology and that, but they can barely turn their laptop on.
Yeah.
Right. And again, I think we're in, I think it's the way it's presented to us. Look at what can do, what can AI do? What can this robot do? What can your laptop do? Look at all the things with the Mac Pros and stuff like that. There's so many functions that we don't use. Why? Because it's not a part of what we do. If you turn it around like I did with Murphy and RoboCop, right? It's like, how can I become an extension of the robot? Instead of what can the robot do for me, what can I do with all of this stuff? I think looking at it from that point of view is the key. And once I figured that out, everything else, the workflow flew easily. It flowed nicely.
So what do you think, what is, in your mind, what comes next? What do you think is going to come next? If we could look into a crystal ball and say, I think we will be using technology in this way. Now, for example, it may be that we're using the same similar robot setup so that a pediatrician can see 100 kids in rural America where there is no access to pediatricians and you're just seeing the ones that are having a problem. But you're, in fact, managing 100, 200 visits, but you're only seeing 10 of them. So things like that. Where do you see it going?
So it's already starting to move, and it's people that have the innovation and the forward thinking to try new things and different things. There are mobile units now that are geared to do clinics, and they go into rural areas and they have a schedule. On Mondays, they're in this town. On Tuesdays, they're in that town. And you can actually have little consultation rooms in these mobile things. And you can have, for example, you can even do peds in one room, neurology in another room, pulmonary in another room, cardiology in another room, and bring it, and even bring it for visits also.
Weren't you working on something like that?
Was back in around COVID time, but yeah, that didn't pan out because of money, really.
Yeah, it looked expensive.
Yeah, that was, and it all comes down. It does come down to money, but there are grants out there and so forth that could be used. The other thing, I don't know where you are, but this has been going on for several years now, is stroke ambulances. Have you heard about stroke ambulances? So these are specific ambulances that have a CT scanner in the ambulance. And they've got a little robot in the ambulance so that you can talk to the neurologist. So they'll go to a stroke call. And again, this is more on actually, it's Cleveland Clinic is using it. And here, I know in Europe, they're using it also, is that either a regular ambulance would go there, and if it's a stroke, then they would call the stroke ambulance. Or if it's a stroke call, then the stroke ambulance would go there. It's costs like $1.3 million for this ambulance, but what it does is they've got the arms go down to hold the ambulance in place. They've got a CT scanner in there. They can do the CT scan. They've got a little monitor that comes up that the neurologist can pop up on and actually do their physical examination and do their NIS score and so forth. Get the results of the CT scan pretty much in real time, and then decide right then and there to use thrombolytics or not. So yeah, so that's what what I've been waiting to see a lot is a robotic arm. I think that because of some of the things we can't do procedures. That's one thing, one of the limitations we can't do. We can't do intubations, we can't do central lines or chest tubes. But I think if we can get a robotic arm, because nowadays IVs are started ultrasound guided IVs. So if you can get somebody to put something on your arm and you can see where the vein is, and if you have another, I know people are working on it also, a device that will actually, advance a needle into a vein, then we can start IVs or moving forward, intubation or central lines and stuff like that. I think that with the more technology that's coming up, I think we'll be able to have more specified like ICUs, even like we're doing hospital at home now. I think there's going to be like ICU at home to a point. I think that's where we could be moving.
So, Jeff, I remember all this started in a hospital when you were the big shot director, right?
Yes.
Now it's in your living room.
Yeah.
How did that work out, if you could tell us?
I started, as you said, I started in a hospital, and I had a couple of bigger companies come up to me and ask if I could provide physician services. And I told them yes, we would be like a subcontractor. And then I went to my hospital. I said, unfortunately, I was in a high administrative point of view. I asked them if I could do this on the side and do the telemedicine on the side with these companies. They said no. I said, do you want to do a joint venture? And they said no. So I had to step away from the corporate medicine because I gave my word to these companies. And so I stepped out of the hospital and I stepped into my home office or into a living room.
Wow. That was a big mistake for them.
Yeah, I think so. I think so. Actually, at one point, I converted my garage into a little office until I actually had a place in my house with an office. So yeah, and I love it because I get to bring my subspecialty to places all over the place and that need it. I'm not stuck at one hospital. And sometimes working at smaller hospitals, you're in a hospital and you have only 2 or 3 or 4 ICU patients. And then the rest of the day, what are you doing? You're either going to meetings or you're filling up your time or whatever. So this way, it's more effective medicine also. And then also, you guys know, working in the hospitals, is that, when you go in, you see a patient, you examine a patient, you walk out, you sit in front of a computer, and you start doing your charting. What's going to happen? Another nurse is going to come by and ask you a question. And then another nurse is going to come by and ask you a question. Or somebody else is going to ask. So you get interrupted so many times, it's hard to even finish a note. I don't have that. I can do it right here.
Oh, this is amazing.
And to your point about the smaller ICUs, it's true of anything. You lose your skills.
Mm-hmm.
And that's a big problem, right? So you have the advantage that you might be taking care of 4 ICUs with 3 beds, but you're really taking care of 12 patients. So you're still maintaining your critical skills and you're talking to different specialists and you're still keeping up to date on the stuff. You're not just stuck with the same pulmonary doctor, the same cardiologist, the same ICU doctor taking care of 4 bed units somewhere. And nobody grows because we've done it this way for 10 years. We're all buddies and we all talk on Friday afternoons.
The other thing, coming back to the financial thing that George brings up all the time, is that one physician at that facility, you're paying him a full day's salary for seeing 3 patients. If you're using me, you're only paying me to see 3 patients. You're only paying me a small amount of money. Let's say a physician's making $2,000 for the whole day being there. I'm going to charge you $200 or $300 maybe for seeing 2 or 3 patients. So it's a huge savings. And then I can see where we make it up is where we see our other patients at our other facilities. We charge them a couple of $100 and a couple of $100, and so that then that whole total adds up to a physician's salary, rather than having one physician at one hospital see 3 patients. And I've been there, done that.
Yeah, no, that also happens in the offices sometimes, right? So the office is slow today.
Mm-hmm.
And you're just sitting there going, okay, waiting for a patient to come in. Mm-hmm. And then there's other places where, they're fully booked and they can't see any more patients and they're sending them to the ER. So, it's nice. There are some case uses of this technology. And over the weekend, I read an article in the Wall Street Journal. This might interest you, Jeff, about treatment of obesity in children.
Mm-hmm.
And so there's a telemedicine outfit already that's prescribing generic Ozempic, semaglutide, compounded to children 13 years and older over telemedicine on a subscription basis, without a physical exam, without lab work, without even weighing the patient. The parent just calls in and says, Johnny weighs this much and is this tall. And they're like, okay, they put it on, no, his BMI is over 95%. $99 a month for me to write the prescription, $99 a month for you to get the Ozempic in the mail. And they do that, and they're chomping at the bit to go down to do the same to 6 through 12-year-olds when the study comes out. That, I think, is a bad case use of technology. But again, there's the people behind the camera. The machine's not doing anything wrong. It's just, in my opinion, well, maybe you have a different opinion, it's irresponsible, cavalier to take care of a patient when you don't know what their real weight is. Well, you don't know what hemoglobin A1C is. You don't know if the liver enzymes are. You don't know what their blood pressure is. And
but a lot of these outfits are run by computer geeks and business people, and they hire somebody like you or me to sit behind a screen and prescribe stuff for them. And they don't take input from the physician. Jeff's outfit is the physician leads it. The physician mentors it. The physician tells them what to do. I think that's the right formula.
Yeah, right, that's a bad case use. What are your thoughts, Jeff, on outfits like that?
Those are terrible. Those, in my mind, those are like pill mills. It's terrible, especially when you're dealing with children. I think now I'm very pro for the GLP-1s. I think that they're huge and they're great, but it's not for everybody. And you can't they're dangerous things. First of all, they're injectable. Secondly, is there side effects. And you need to be able to have somebody there that can manage these side effects. Plus, also, weight loss is not just a magic pill. It has to come with diet modification. It has to come with exercise. It has to come with psychological consultations also, because why are they obese? Why are they overweight? Are they depressed? Are they anxious? Are they, who knows what's going on? And then not only that, but we need to guide them through the obstacles and the barriers that come up. So for example, take me for example, I like to nosh at nighttime. I need sweets at nighttime. But if I talk to somebody and they say, why don't you try this or do that? Or if you want the sweets at nighttime, yes, you can have sweets, but you do it in a small amount and do just this amount. And so it will be your nutrition plan. So it will fill your nutrition plan rather than blowing up your nutrition plan. Ozempic, there's a lot of adverse reactions that can occur. Pancreatitis, motility issues of the stomach.
Even if it is a side effect, but the nausea and the vomiting when you start is real.
It is.
And the constipation was a real barrier for compliance for patients.
Mm-hmm. Yep. And all of those need to be, you need somebody there that you can talk to. Now, can you provide these services via telemedicine? Yes, but it needs to be on a continuous basis. It can't be, okay, here's your drug and that's it. You need to see the patient. You need to have the labs. You need to monitor the patient. And you need to have all the different aspects. And it's not necessarily a physician, but you need a counselor. You need somebody to talk to them on a daily basis. You should need to see their weight on a daily basis. You need to evaluate the adverse reactions or the reactions to it. What are they feeling? How are they doing? What's their diet? What's their exercise? Because there's studies that show if you just take Ozempic, you're going to lose muscle mass, and you become dysmorphic. And so we don't want that to happen either, especially in children, because then they become dysmorphic. They're going to have further eating disorders. They're going to become depressed or anxious or whatever. And those are the things they need counseling.
Wow.
Yeah. Yeah. No, absolutely. And then I have this is really a philosophical question. Do we treat obesity because of the cosmetics? Or is there people do? Liposuction has been around forever. But when you're treating obesity as a disease, are we treating it because we know in the adult it decreases cardiovascular events? It decreases cancer. It decreases joint replacements. And it prevents type 2 diabetes. That's why I think we treat people with high cholesterol with Lipitor.
Yeah.
It's not that high cholesterol really means anything. It's just that we know that if we put you on Lipitor, you'll have less cardiovascular events. Otherwise, we wouldn't treat you.
Yeah.
So is that in children in particular, isn't the end goal to prevent bad outcomes, not just to make you skinny so you can get into your prom dress?
You're absolutely right. And yes, that's the reason why I do it. And that's the reason why I think we as a physician group should do it. Not for aesthetics or to get into your prom dress.
Yes, yeah.
Yes. I think that, and I think if we start earlier with the children and they don't get to be obese, I think that will help. Thinking through things, lots of people don't understand is that extra weight on the body is extra weight it's an extra stress on the body. Right? Everything is. I was just had a conversation with my mother the other day, and she was talking about large bones people and thin bone people. I said, Mom, bones are the same pretty much. Everybody has the same, relatively, a very similar skeleton. Some people have got this much extra on top of it, whereas some people only have this much extra on top of it. Even going to the ventilator, okay? We used to use tidal volumes depending on your body weight because we thought the bigger people have a bigger chest. No. The chest is this small, and then all the rest is adipose tissue. So we have to use the same. We use the predicted body weight now, so we can't over. Yeah, because everything is extra. So when you're dealing all the extra weight to lift up your legs, to lift up your arms. I've gotten into fitness. If I do pull-ups and I'm 150 pounds, I can do, let's say, 10. If I'm at 140 pounds, I could do 20. So that extra 10 pounds makes a difference. And then we were just talking about this also with my mom, is think about a patient, an ICU patient, okay? That's 400 or 500 pounds, okay? How are these nurses that weigh 120 pounds going to take care of this patient, okay? This patient is sedated on a ventilator. They're going to have bowel movements. How are we going to clean them up? We have to turn them. And turning 400 or 500 pounds one way, turning 400 or 500 pounds the other, lifting up a leg, that's going to be 50 pounds or something like that. It's very difficult.
Not only that, Jeff, sorry to interrupt you. What peak do you give somebody that's 450 pounds laying on their back? Because you're going to need more pressure to get those lungs to expand fully and not collapse when the abdominal adiposity just pushes up the diaphragm and boom, Correct. There you go. Now you got atelectasis at the base, and now you're going to get a pneumonia. It's that easy, right? It's the access weight.
Even starting an IV is more difficult.
Very difficult.
Starting a central line is more difficult. Doing a tracheostomy is more difficult. Intubating somebody is more difficult with obesity. Obesity, it's not just, yes, it's got so many different aspects of chronic health issues. That's probably the major one. Also, if you look good, you're going to feel good. I think most, I don't know if I should say this on camera or what, but more so women with, I feel good, I feel sexy, then they are sexy. Men are, I'm okay. But again, when you feel good and you feel good about your body, men also, because my body's now in shape, I feel better about myself. At a certain time, I would go to a pool, I wouldn't take off my shirt. And I live in Florida. So now I don't mind taking off my shirt. So it's the whole feeling, and it will help your mental health also.
Yeah, and I think to your point there, I think that exercise is key. Because some of it is so bizarre, it just doesn't make any sense. But if you can get into a regular exercise routine, you gain energy from the exercise, which you should be tired from exercising. But it's the opposite. There's a surge of energy, and even if you don't really care how handsome you are when you look in the mirror, but you have more energy, and that makes your mental health so much better. That surge of energy.
What it also does is that surge of energy gives you the extra energy during that time. But when it's time to go to sleep, you'll probably get a better sleep. So sleep is also a very important part of weight loss. You have to have good sleep. Stress factors also have to be controlled and dealt with. Otherwise, I would say a majority of patients eat because they're depressed or they're not feeling well or something like that.
Yeah.
I think that
it's like a teenager who drinks vodka because she's anxious, right? Yeah. If you're anxious and you take a couple of shots of vodka before you go out to the party, now the anxiety is down. You're more social,
right?
And food is the same way. People use it as a crutch to decrease their anxiety. And then they get used to that habit, and then they pay the price. Well, George, is there any more questions you want to ask, Jeff?
Yeah, I think we should finish this subject off with, what advice would you give to physicians that are considering tele-ICU work out of the gate? I don't think that this is a job for a new grad.
No.
I think you have to become a Jedi Master first, and then it takes time.
Yeah. So I mean, it should be physicians that feel comfortable in an ICU. It should be physicians that feel comfortable doing telemedicine. I can tell you, there are so many physicians I've talked to that I'd say, why don't you do this? This is great. They need to be at the bedside, and you can't convince them. The other thing is procedures. You have to, if you're going to do this full time, most of my physicians are doing it part time, but I have a couple of physicians that are doing it full time. You have to be okay with stepping away from doing procedures and knowing that skill is going to get rusty. I've done thousands of intubations and central lines and chest tubes and so forth. Do I miss doing them? No. Would I be able to do them in a pinch? I think so. I believe so. So it's a physician that feels comfortable working in an ICU, a physician that feels comfortable not doing procedures, more thinking, and physicians that want the flexibility to be able to do this. There's pluses and minuses. You give up your procedures, you've got the flexibility of being at home, you've got the flexibility of your own schedule. And so I would say whoever is interested in it, I would say do it. I did have some pulmonary fellows when they were in their third year fellowship that wanted to do an elective with us to learn a little bit about the tele-ICU and how to manage the patients. I think that's a great idea. You're there, you're mentored with a physician, because you will be asked and it will come up in your career if you wanted to do telemedicine at some point. And I think you should have some experience with it and be familiar with it.
Is this part of training today?
Not yet. It's not mandatory.
It's not mandatory training.
No.
So wow.
There are some electives that are doing it.
Interesting. So you got to get hooked up with a school again.
Yep.
All right. Very fascinating story, even though he's not a pediatrician.
Yeah, sorry about that. I can't do kids.
Thank you, Kev. It's always wonderful to talk to you.
Yeah.
Hope to see you soon and your beautiful wife and all that soon.
You're right. Great talking to you guys. Send Deli my love.
I will.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.